Chapter 62 Neural Regulation of Respiration. The nervous system normally adjusts the rate of alveolar ventilation almost exactly to the demands of the body so that the PO2 and PCO2 in the arterial blood are hardly altered, even during heavy exercise and most other types of respiratory stress. Coming to the respiratory center, it is composed of several groups of neurons located bilaterally in the medulla oblongata and the pons of the brainstem. Okay, so in the pons, you have two types of two groups that regulate respiration. In the upper pons you have the pneumotaxic center, and in the lower pons you have the enuestic center. Okay, the enuestic center, it prolongs inspiration, it prolongates enuestic prolongates inspiration, and the pneumotaxic center, it inhibits the enuestic center. So the pneumotaxic center, it is inhibiting inspiration. Okay, so it is, the inspiration is inhibited to short intervals, so that is why the frequency increases as the time period is decreasing. So respiratory rate increases because of the pneumotaxic center. Coming to the medulla, we have the pre-Botzinger complex, which initiates the respiration, and we also have the DRG and the VRG. Okay, dorsal respiratory group, which is mainly responsible for inspiration, and ventral respiratory group, which is responsible for both inspiration and expiration, but mainly expiration. Okay, so a respiratory center is composed of several groups of neurons located bilaterally in the medulla oblongata and the pons of the brainstem. It is divided into three major collections of neurons: a dorsal respiratory group located in the dorsal portion of the medulla, which mainly causes inspiration; a ventral respiratory group located in the ventrolateral part of the medulla, which mainly causes expiration; and the pneumotaxic center located dorsally in the superior portion of the pons, which mainly controls the rate and depth of breathing. So coming to the DRG group of neurons, they play a fundamental role in control of respiration and also the respiratory rhythm. They extend through most of the length of the medulla. See, you can see that the DRG group, it extends most through the length of the medulla. Okay, most of its neurons are located within the NTS, that is nucleus of tractus solitarius, although additional neurons in the adjacent reticular substance of the medulla also play important roles in respiratory control. The NTS is a sensory termination of both the vagal and the glossopharyngeal nerves, which transmit sensory signals into the respiratory center from peripheral chemoreceptors and baroreceptors. Okay, so now coming to the rhythmical inspiratory discharges from the DRG, the basic rhythm of respiration is generated mainly in the DRG group of neurons. Even when all the peripheral nerves entering the medulla have been sectioned and the brainstem has been transected both above and below the medulla, this group of neurons still emits repetitive bursts of inspiratory neuronal action potentials. The basic cause of these repetitive discharges is unknown. In primitive animals, neuronal networks have been found in which activity of one set of neurons excites a second set, which in turn inhibits the first. After a period, the mechanism repeats itself, continuing throughout the life of the animal. Most respiratory physiologists believe that some similar network of neurons is present in the human being, located entirely within the medulla. It probably involves not only the DRG but also adjacent areas of the medulla as well, and it is responsible for the basic rhythm of respiration. Inspiration, that is. Coming to the inspiratory ramp signal, the nervous signal that is transmitted to the inspiratory muscles, mainly the diaphragm, is not an instantaneous burst of action potentials. Instead, it begins weakly and increases steadily in a ramp manner for about 2 seconds in normal respiration. It then ceases abruptly in the next 3 seconds, which turns off the excitation of the diaphragm and allows elastic recoil of the lungs and the chest wall to cause expiration. So it goes something like this. Okay, so it starts, it prolongs gradually, and then in the first 2 seconds, and then in the next 3 seconds it abruptly ceases. Okay, this is the inspiratory ramp signal. Next, the inspiratory signal begins again for another cycle. This cycle repeats again and again, with expiration occurring in between. Thus the inspiratory signal is a ramp signal. Okay, the obvious advantage of the ramp is that it causes a steady increase in the volume of the lungs during inspiration rather than inspiratory gasps. Okay, so here you can see how all of these, they cause firing of the DRG group of neurons in the NTS. Okay, which is responsible for increasing the rate of increasing the depth of inspiration and all that. The VRG mainly causes expiration and also inspiration to some extent. Pneumotaxic center, it inhibits the DRG firing in order to increase the respiratory rate. Okay, Now, two qualities of the inspiratory ramp that are controlled are as follows. Control of the rate of increase of ramp signal, so that during heavy respiration, the ramp increases rapidly and therefore fills the lungs rapidly. Control of the limiting point at which the ramp suddenly ceases, which is a usual method for controlling the rate of respiration. That is, earlier the ramp ceases, the shorter is the duration of respiration. So this method also shortens the duration of expiration, increasing the frequency of respiration or the respiratory rate. Okay, so you are controlling the rate of increase and also the you are controlling the limiting point. Pneumotaxic center, it limits the duration of respiration and increases the respiratory rate. A pneumotaxic center located dorsally in the nucleus parabrachialis of the upper pons transmits signals to the inspiratory area. The primary effect of the center is to control the switch off point of the inspiratory ramp, thus controlling the duration of the filling phase of the lung cycle. When the pneumotaxic signal is strong, the duration will decrease. The inspiration might last for as little as 0.5 seconds, thus filling the lungs only slightly. When the pneumotaxic signal is weak, the duration is prolonged and inspiration might continue for 5 or more seconds, thus filling the lungs with a great excess of air. The function of the pneumotaxic center is primarily to limit inspiration, which has a secondary effect of increasing the rate of breathing, because limitation of inspiration also shortens expiration and the entire period of each respiration. A strong pneumotaxic signal can increase the rate of breathing to 30 to 40 breaths per minute, whereas a weak pneumotaxic signal may reduce the rate only to 3 to 5 breaths per minute. Okay, coming to the VRG group of neurons, they function in both inspiration and expiration. Located in each side of the medulla, about 5 mm anterior and lateral to the DRG group of neurons, is the ventral respiratory group of neurons, or the VRG group, in the nucleus ambiguous and the nucleus retroambiguous. The function of this group differs from that of the DRG in several ways. The neurons of the VRG group remain almost totally inactive during normal quiet respiration, because normal quiet respiration is a passive process. It is caused only by repetitive inspiratory signals from the DRG group, normal inspiration. And expiration results only and only from the elastic recoil of the lungs and thoracic cage passively. So the neurons of the VRG group remain totally inactive during normal quiet expiration. The ventral respiratory neurons do not appear to participate in the basic rhythmical oscillation that controls the respiration. Okay, DRG group controls the basic rate. When the respiratory drive for increased pulmonary ventilation becomes greater than normal, respiratory signals spill over into the ventral respiratory neurons from the basic oscillating mechanism of the DRG area. As a consequence, the VRG area contributes to extra respiratory drive as well because of spillover of signals. Electrical stimulation of the few of the neurons in the ventral group causes inspiration, whereas stimulation of others causes expiration. Therefore, these VRG neurons contribute to both inspiration and expiration. They are especially important in providing the powerful expiratory signals to the abdominal muscles during very heavy expiration. Thus, this area operates more or less as an overdrive mechanism when high levels of pulmonary ventilation are required, especially during heavy exercise. Coming to the peripheral inputs affecting the respiration, including the peripheral receptors, there are several peripheral receptors that help in control of respiration. The levels of O2 and CO2 are detected by the central and peripheral chemoreceptors, and the other peripheral receptors that have an influence on respiration are mechanoreceptors. So coming to the Herring-Breuer inflation reflex, lung inflation, it signals to limit inspiration. Okay, sensory nerve signals from the lungs, they also help control respiration. Most importantly, located in the muscular portions of the walls of the bronchi and bronchioles throughout the lungs are stretched receptors that transmit signals through the vagi into the DRG group of neurons when the lungs become overstretched. These signals affect inspiration in much the same way as signals from the pneumotaxic center. That is, when the lungs become overly inflated, the stretch receptors, they activate an appropriate feedback response that switches off the inspiratory ramp and thus further stops inspiration. This is called the Herring-Breuer inflation reflex. This reflex also increases the rate of respiration, as is true for signals from the pneumotaxic center, because you are reducing the duration of respiration, so the rate of respiration increases. In humans, the Herring-Breuer reflex probably is not activated until the tidal volume increases to more than 3 times the normal, that is greater than 1.5 liters per breath, because the normal is 500 ml. And therefore, this reflex appears to be mainly a protective mechanism for preventing excess lung inflation rather than an important gradient in the normal control of ventilation. Coming to the control of overall respiratory center activity, up to this point we've discussed the basic mechanisms for causing inspiration and expiration, but it is also important to know how the intensity of the respiratory control signals is increased or decreased to match the ventilatory needs of the body. For example, during heavy exercise, the rate of O2 usage and CO2 formation are often increased to as much as 20 times the normal, requiring commensurate increases in the pulmonary ventilation. Coming to other factors that affect respiration, let's talk about the voluntary control of respiration. For short periods, respiration can be controlled voluntarily, and one can hyperventilate or hypoventilate to such an extent that serious derangements in PCO2, pH, and PO2 can occur in the blood. Coming to effect of irritant receptors in the airways, the epithelium of the trachea, bronchi, and bronchioles is supplied with sensory nerve endings called pulmonary irritant receptors that are stimulated by many incidents. These receptors initiate coughing and sneezing. They may also cause bronchial constriction in persons with diseases such as asthma and emphysema. Coming to the function of lung J receptors, J here stands for juxtaposing. A few sensory nerve endings have been described in the alveolar walls in juxtaposition to the pulmonary capillaries, hence the name J receptors. These J receptors were first described by an Indian scientist, Ottar Singh Pentel, in 1955. So they are stimulated especially when the pulmonary capillaries become engorged with blood or when pulmonary edema occurs in such conditions as congestive heart failure. Although the functional role of the J receptors is not clear, their excitation may give the person a feeling of dyspnea. This is why dyspnea is called when a person has pulmonary edema, because of the firing of the J receptors, which fire through unmyelinated vagal C fibers. Okay, these are the afferents. Brain edema, it depresses the respiratory center. Okay, also remember that the J receptors were discovered by an Indian scientist, Avtar Singh Pental. Now, coming to brain edema, it depresses the respiratory center. The activity of the respiratory center may be depressed or even inactivated by acute brain edema resulting from brain concussion. For instance, the head might be struck against some solid object, after which the damaged brain tissues swell, compressing the cerebral arteries against the cranial vault and thus partially blocking the cerebral blood supply. Occasionally, respiratory depression resulting from brain edema can be relieved temporarily by intravenous injection of hypertonic solutions, which actually, absorb water into the hypertonic solution in order to, relieve the excess water that is causing excess pressure there. So we can use hypertonic solutions such as highly concentrated mannitol solution for this purpose. These solutions osmotically remove some of the fluids of the brain, thus relieving intracranial pressure and sometimes re-establishing respiration within a few minutes. Coming to anesthesia, perhaps the most prevalent cause of respiratory depression and respiratory arrest is overdosage with anesthetics or narcotics. For instance, sodium pentobarbital, it depresses the respiratory center considerably more than many other anesthetics such as halothane, which is the fluoride-based anesthetic as far as I remember. At one time, morphine was used as an anesthetic, but this drug is now used only as an adjunct to anesthetics because it greatly depresses the respiratory center while having less ability to anesthetize the cerebral cortex. Now, coming to abnormal breathing patterns, there are several types of abnormal breathing patterns. They are listed as follows. We have chain strokes breathing, we have biots, ataxic breathing. Okay, B and A. A is first in the alphabet. Ataxic breathing, or also known as biots breathing. We also have anaeustic breathing and Kussmaul's respiration. Coming to periodic breathing, an abnormality of respiration called periodic breathing, it occurs in several disease conditions. The person breathes deeply for a short interval and then breathes slightly or not at all for an additional interval, with the cycle repeating itself over and over. Okay. One type of periodic breathing called chain strokes breathing is characterized by slowly waxing and waning respiration occurring about every 40 to 60 seconds. So this is what happens. There is a period of ventilation followed by no ventilation at all, and again a period of ventilation followed by no ventilation at all. Okay, the basic mechanism of chain strokes breathing is the following. When a person overbreathes, thus blowing off too much CO2 from the pulmonary blood while at the same time increasing blood oxygen, it takes several seconds before the changed pulmonary blood can be transported to the brain and inhibit the excess ventilation. By this time, the person has already overventilated for an extra few seconds. Therefore, when the overventilated blood finally reaches the brain respiratory center, the center becomes depressed to an excessive amount, at which point the opposite cycle begins. That is, CO2 increases and O2 decreases because of hypoventilation or no ventilation at all. Again, it takes a few seconds before the brain can respond to these new changes. When the brain does respond, the person breathes hard once again and the cycle repeats. So you have a CO2 buildup. Okay, when CO2 builds up because of no breathing at all, you need to hyperventilate. So you hyperventilate, and again your CO2 it reduces. Then you hypoventilate to cause an additional buildup of CO2. So this is what happens in chain strokes breathing. However, under normal, see, the basic cause of chain strokes breathing occurs in everyone. However, under normal conditions, the chain strokes breathing mechanism is highly damped. That is, the fluids of the blood and the respiratory center control areas have large amounts of dissolved and chemically bound CO2 and O2. Therefore, normally the lungs cannot build up extra CO2 or depress the O2 sufficiently in few seconds to cause the next cycle of periodic breathing. But under two separate conditions, the damping factors can be overridden and the chain strokes breathing does occur. When a long delay occurs for transport of blood from the lungs to the brain, changes in CO2 and O2 in the alveoli can continue for many more seconds than usual. So when there is a long delay in transport of the blood, this occurs during cardiac failure. Okay. So under these conditions, storage capacities of the alveoli and pulmonary blood for these gases are exceeded. Then after a few more seconds, the periodic respiratory drive becomes extreme and chain strokes breathing begins. This type of chain strokes breathing often occurs in patients with severe cardiac failure because blood flow is slow, thus delaying the transport of blood gases from the lungs to the brain. In fact, in patients with chronic heart failure, chain strokes breathing can sometimes occur on and off for months. A second cause of chain strokes breathing is increased negative feedback gain in the respiratory control areas, which means that a change in blood CO2 or O2 causes a far greater change in ventilation than it would normally cause. For instance, instead of the normal 2 to 3 fold increase in ventilation that occurs when the PCO2 rises 3 mm of Hg, the same 3 mm of Hg rise in PCO2 might increase ventilation to 10 to 20 fold instead of the normal 2 to 3 fold. The brain feedback tendency for periodic breathing is now strong enough to cause chain strokes breathing without extra blood flow delay between the lungs and the brain. This type of chain strokes breathing occurs mainly in patients with damage to the respiratory centers of the brain. The brain damage often turns off the respiratory drive entirely for a few seconds, then an extra intense increase in blood CO2 returns it back on with great force. Chain strokes breathing of this type is frequently a prelude to death from brain malfunction. Okay, so here note that the PCO2 of pulmonary blood changes in advance of the PCO2 of the respiratory neurons. Okay. However, the depth of the respiration corresponds with the PCO2 in the brain, not with PCO2 in the pulmonary blood where the ventilation is occurring, because that is where the centers are located in the brain. Coming to Biot's breathing, it is a rare condition, as you can see here, where an abnormal breathing pattern occurs in patients with acute neurological disease. Okay, this is also called ataxic breathing. Okay, and it is characterized by unpredictable irregularity. There may be quick bouts of shallow respiration followed by unpredictable periods of apnea. It may be caused due to lesions in the medulla oblongata. It is named after Camille Biot, a French physician who characterized this breathing. And coming to eniustic breathing, as you can see right here, the term eniusis is derived from Greek meaning breath holding. It was first described in the year by Willy Markwald in the year 1888. This type of breathing is characterized by a prolonged inspiratory gasp with a pause at full inspiration. Prolonged inspiratory gasp, okay, prolonged inspiratory gasp with a pause at full inspiration. This type of breathing is usually caused due to lesions at the dorsolateral lower half of the pons. Okay, eniustic center is located in the lower part of the pons, pneumotaxic in the upper part. So lesions in the eniustic center in the lower part of the pons in the dorsolateral aspect, it causes eniustic breathing. Now finally we have Kussmaul's breathing. In this type of abnormal breathing is characterized by very deep labored regular breathing, sometimes with increased frequency. Very deep labored breathing. Okay, it is named after a German physician, Adolf Kussmaul, who first described this in the year 1874. Kussmaul's breathing is seen in patients with metabolic acidosis and more commonly in patients with diabetic ketoacidosis. So in diabetic ketoacidosis, you see Kussmaul's breathing. Okay, diabetic ketoacidosis is a form of metabolic acidosis, hence you see Kussmaul's breathing. Kussmaul's breathing, immediately remember diabetic ketoacidosis. Okay, so this is what is summarized in this table here.